Okay, thank you very much, and thank Ahin to invite me have a short speech here. So I think that today's my topic is driving the next generation healthcare transformation in Taiwan, and main focus on the FHIR implementation and the regional insights. So currently, we design a lot of different fundamental design a lot of different architecture for the implementation of FHIR, and also based on our government national health. Actually, our Ministry of Health already have some policy to improving everybody adoption of FHIR in the hospital. So let me to introduce a little bit. So today's my speech we have separate to the three different parts. So first is currently status in the AI and the machine learning application, and second is we have a foundation of the AI. We doing the data preparation and then research design, and third is next generation healthcare transformation. So actually, we learning a lot from the international. So start from the I think it's 2021, the UK and the US and also the Canada, they have announced the good machine learning practice in October 27, and then they have in the 2024 last year they more focus on the transparency, and then they have continually adjust the regulation and the review method. So actually, we learning from a different country a lot to decide our regulation about the machine learning and then all related product, how to implement and how to go into the marketplace. So in the Taiwan, in the 2022, we have a medical software classification and the grading reference guide. So we separate the medical software into two different kinds. So the first one is a medical device software, and another one is a non-medical. The so-called the medical in the medical device software, they divided to the three different classes, and then this three kind of the medical device software, they must comply with the TFDA medical device regulations. And in the non-medical parts, which including the administrative management system or medication recording, calculation or medication dosage software. So this kind of the supporting software or health promotion software is no need to combine with the TFDA medical device regulation. So that's we can say everything related to the patient directly one will become the medical device software, and then they need to must comply with the TFDA medical device. So right now is our currently status in the device sites. So for example, the medical device software also part of the medical device pay actually in the national health insurance they already pay the part of the medical device software for pay for the use and pay for everything. So client to have the diagnosis or treatment function or asset assistant for a diagnosis or treatment one will become kind of a medical device. And also that is also under the national health insurance covered part of them. So for example, the medical image processing software, the computer assets medical equipment software, or surgical treatment plan software, or the telemedicine or care and the care software. So this all kind of different software are kind of the medical device in the Taiwan's regulation. So when they want to go into the marketplace, they need to get a TFDA certificate first, and then they can sell their products. So in the Taiwan, actually in the Taiwan right now, we will separate to the two different ways. So first one is in the hospital sites. They don't get they design a lot of different software by themselves, or design a lot of different AI model by themselves, but they are not got the TFDA certificate, because in the hospital side they can using that for the assist themselves to doing the diagnosis or for the patient treatment or patient care. But if they want to go into the marketplace, they need to doing that. So another side is in the industry side. They want to get the data and design a lot of different model or design some software for for hospital use. So they need to get the TFDA certificates, and then they can go into the hospital. So that is a totally different way to adoption this kind of a model or this kind of a software. So basically, when we have the model, before the model, we need to get the data. So let's go back to the data preparation and the research design. So in our perspective, we precision medicine that we can divide it divide it to the two parts. The first one is the data requirements, and another side is application requirement. So I think in our perspective is the good data we need to have an advantage of the population coverage, and then can cover all life courses, and also including the disease prevention, treatment, care, and then long-term tracking, and the data can be able to incorporate with the various data. For example, EHR genomics, genomics report, image, or lifestyle questionnaire, or mobile wearable device data. And in the application side, we need to focus on the research data and also the industrial data need for the R&D, and then emergency pharmaceuticals and the medical materials. And also we need to connect the international data platform and the cross-agency data exchange needs. And so based on the FHIR to allow the data be used, and also based on the FHIR or OMAP format to doing that. And also the information security usage environment is a very important part. So because I'm working under a National Health Research Institute, so we design all kind of different precision medicine in the hospital setting. So in this slide, we think in the past, it's patient, we get the genomic results, and then we can have some treatment options. And then the image data can for the supporting diagnosis, and then the traditional outcome only is patient survival rates. But modern strategies emphasizing the treatment response, the disease-free, prognosis-free, toxicity, and then quality of life. So right now we try to get the clinical data in the timely and then programming setting to get back the data for supporting our treatment option. So the so-called continually improving the patient care. So everything is based on the outcome, and then go back to the treatment options, and then we can try to improving their care and then their survival rate. So this so-called the real world data, how to using it, how to collaborate, and how to put everything together, and then make the patient and support the patient make a more better decision. So in the patient journey side, we need to have a sufficient information for precision medicine. So in the right now, for example, when we have when one patient have get a cancer, so first of all they have a diagnosis, and then they're doing the surgery or radiation. And then we will have a different line of the treatment for the therapy. And then we need to base on all different kinds of the outcome from the last status to make the change. So we can base on the disease, the diagnosis stage and the staging, and then biomarker to design the first line therapy. And then based on the remission progression to design the second line therapy. And everything we need to also consider about the treatment response, adverse effect, and then recurrency. So the patient journey can be divided into the stage based on the different disease treatment and the outcome. And then we need to, based on their outcome, to design the next layers therapy, or next stage therapy, or how to make the decision. So from the National Health Research Institute, we designed all Taiwan Biobank data collection system. So we designed, first of all, we designed a Taiwan common data model. So in this common data model, we focus on the patient. So we have the patient information, disease information, treatment information, outcome survival, and then progression-free information, and lab data. And also we collaborate with for the genomic. So once the patient join us, and then once they get in the genomic repo, we can get everything together. And also we try to get we just try to get the data automatically from the EHR. So we have the structured data and the unstructured data. So right now we just get the aggregate data from the EHRs for the direct feed, and with no requirement for the clinician to capture the data in a specific format. So based on the system and based on this kind of the processing, we can get the data more smoothly and then more efficiency and more correct. And so right now, in the first stage, we just get the structured data right now. And then we also get some repo, the free text repo as unstructured data. And we use in the large language model and also the and the natural language processing to doing the data analysis to capture the more specific data from the repo to getting everything together. So once we getting the data, we need to focus on the data quality management and the inspection. So we designed several different data indicator for the checking. So major focus on the data accuracy, consistency, and then integrity, and then availability. So we need to make sure the data is correct and realistic, and also the consistency across the different systems and applications. And also we need to make sure the data is complete and without omissions. And also the data is available for for the analysis and the users. So in the list side, we divided, focus on these 4 different indicators group. We just divided to the 16 important data quality dimensions to control the data. So for example, we have a security. We need to make sure the hospital's secure data collection or data storage platform or that system is the security is enough for protect all the data. And also we make sure our data is easy for use. So in the National Health Research Institute, we have the data center and provide the computer, provide the all environment, all computer service or all data analysis tool for the data analysis. So we just we just try to using the different dimensions data quality control method to make sure our data is usable and also can support the clinical research. So for example, we have an automatic data analysis processing. So we will get the data and then get the all indicator result directly. So for example, we have some pie chart and then some calculation, some statistical result here. And also for example, we will calculate some continuous data. For example, is a height is high, is a height data. So the height is we will calculate the height is number and the shortest one, and also the mean, the missing value, and also the fifth percentile, Q1, Q2, Q3, and then 95 percentiles. So everything, when we get the data, we can do in that automatically and then get a report to the user. So this, which means when the researcher apply the data from our platform, and we will provide this kind of the quality control and the quality report to them, and then they can make sure that everything they get, the data they're getting is okay or is fit for their purpose, so they can do in the data analysis. So this is our whole platform structure. So also we need to facing the data privacy issue. So before they apply the data, all the data will storage inside the hospital's biobank. Once we get in the application, and then in our National Health Research Institute, under us we have a National Biobank Consortium, Taiwan. under this consortium, once we getting the approved application, we will send the application to the hospital, and the hospital side they can do it again to their have the tumor board and then their IRB and everything again, and then once they also they approve, the data will through the processing to get the data and then go into the national biobank consortium in Taiwan and this central platform, and then we will getting the data together and then we provide to the user analysis the data and control everything for them. So we have a trusted research environment. So in this environment, the researcher only can using the data at this environment. So including the data analysis and then including the report output will controlled by us. And also the all data is encrypted storage in our environment. So we also design something the database construction. So we just based on our common data model and then also our genomic report, and then we just based on the different disease to design the different things data. So the data collection on the patient treatment processing is sufficient for the research and the use of the precision medicine. So also in the based on this everything, we also face on the international collaboration or international format or standard things. So in the list data platform, we also convert the common data model and the genomic report into the M code format, just follow the USA way. So in the M code, they have the 6 different group of the data. They just divided they design the minimum common oncology data elements. So they divided the cancer patient into the 6 different group of the data. So including the patients, the provider, payer, vendors, and then government and the regulatory, and then also research. And so they provide data to them. And the 6th group is patient disease, genomic, lab, outcome, and the treatment. Actually, this is super similar to our common data model. Actually, we just follow their way to doing that because in the Taiwan, we also have a lot of different cancer patient and then cancer research issue. So we just follow this way. But based on this M code, we just design another is so-called Taiwan common data model. We just separate to the cancer and the non-cancerous patient, and then because in the cancer patient, we will extend for the human specimen and also the all kind of the cancer information for the cancer status, the TNM staging or everything here. But in the non-cancer, so we just have some condition. So that is a different situation, but we need to incorporate everything together. So for the future, we can using it together directly. So this is the platform we designed under the National Health Research Institute, and also we right now we collaborate with more than the 31 hospital to doing this kind of the design. So based on the regulation from the medical device software, we can collection the data, and then based on this kind of the data platform, and install inside the hospital and control and manage the data in the hospital. And then also we can get in the research data output for the researcher. So the third is our government just think about the next generation healthcare transformation, because this is everything for free from the government side. So that is not totally right. They need to they try to create the marketplace, allow the industry to join and design their products going into the market and supporting the hospital. So everything will go going more smoothly and collaborate more smoothly. So in the next generation medical information architecture, the infrastructure construction promotes the transformation and then creates a new situation for the international collaboration. So in my side, I just separate to the 2 different way. From first one is the two different parts. The first one is the information. So from the data side, we information system, we have sensing and then monitoring devices, or the graphic processor, or the big data analysis, or AI or machine learning from this side. So they need to get all the data for the data analysis. In the communication side, we need to internet communication technology, or a mobile network, or wireless communication, or satellite communications. So based on these 2 ways, we can for we can service the patient more smoothly and then more helpful. But based on this ICT way, we need to consider about the hospital must consider about the efficiency and the costs. And also in the personal side, they need to consider about the precise and the customized. And also based on the both hospital side and the personal side, they need to consider about the quality and the access. So for the hospital side, they need to upgrade the medical information system. They need to have the nursing and the care information system and the administration management system. And they want to create everything connect together, integrated together. And also for the personal side, the based on the they need to focus on the healthcare. So the personal physiology data collection and then genetic testing and then data risk prediction and also the health prevention. And in the nursing care treatment effect to the prediction, evaluation, health assistance, and the medication management. So they have the different sides. The hospital need to control everything to very well. And person side, patient side, they need to control their self very well. So based on this kind of the integrate, we can we can get the high quality and then high quality diagnosis and treatment in the health supporting system. So also from our government side, they need to try to design the whole next generation medical information architecture. So we just think about to follow the international way. So focus on so we follow the US way. United States, let's start from 2009. They have a meaningful use, and then 2020 they have a 21st century curious, and then 2021 they have a CMS, and then they have a regulation about the patient access, and then 2022 they have a FHIR, and then 2023 they have a QHIN. So focus on based on this kind of architecture, they have the regulation, standard, and then application for everything. So regulation just rule their markets and then their service provider. They need to have follow the international format. They need to follow the patient access and everything. And the standard side, they design the interoperability. So based on the FHIR, they can have the data exchange directly, and they have the USCDI for the data, their common data model. And also they need to have the patient access service, so the patient can access the data for their self, and then they have the certification processing and then monitoring all stakeholder for the health IT service. And also they have a report and the client for the information blocking. So in the application side, it's more funny to us because from the Taiwan side, we don't have we don't have too many applications in the marketplace because it's hard to engage the all information into the hospital or engage with them. So all kind of the service is under control the hospital sites. But right now they've discussed about the integration, the international standard. So it's more efficiency to doing the data engagement and the system engagement. So in the US side, they discuss about standard and certificates for the health IT to improve the health equity. And also they asking them to provide the patient access to the health record. So the patient access information for the individual, for the provider, for the EHR vendor, for the research and the data. So this is what we're doing right now. And also follow their way, we design our FHIR TW core IG. So they are start from the 2023, 2022. Before that, they already have a USCDI. So every year they will have the pilots, and then they will have a group of people discuss, and then they have the final version of their current status. But we just follow their way to design the Taiwan Core IG. So Therefore, journey of the U.S. course is declared and candidacy, and then get published and then pilots and propose for the U.S. court to the U.S. Remain Steering Committee. So they have a committee and submit the STU update or the bullets. So they have a all journey of the every year. They need to go in the one processing to announce a new version of the data standard. So we also follow that way to doing that. So in the last year, July 17, they have a rule for health data technology and the interoperability. So and they also asking their vendor their industry to provide the API certification for their user to get the data directly. So also we just follow their way. So you see here, Taiwan have the Taiwan CDI, Taiwan Core IG, and then in this year, our National Health Insurance Administration, they discuss about the bulk data access. And then everything will based on the smart applications way to doing that, and also you using the HL7 FHIR. And for the application side, we design the CDS hook and the validator, the everything. So start from the government. So also they also consider about in the Taiwan side also follow the CMS patient access to design this kind different kind of API to get the data. So let's and also in the data exchange side, the TEFCA, they have three different goals. First one is establish a universal policy and the technology flow to the nationwide interoperability. But based on this side, in Taiwan, we already have the EMR exchange center, already have more than 15 years. So under the Taiwan EMR exchange centers, the hospital have the server and get the 4 different formats of the data of the patient data in the that server. So once patient go into another hospital, they can say, I have the data in the hospital A, so that you can using my national health insurance card to access the data directly to get the data from that server. So in the EMR exchange center, so-called EEC, is a kind of the hook is a gateway or is a hook in the middle side. So all hospital can through the hook to get the data from a different hospital. So I think that is very similar to the TEFCA's structure. But in that moment, that the EMR exchange center, they don't follow the FHIR format. So they're just using the part of the FHIR CDR2 format to doing the data exchange. And also all kind of hospital need to install the system directly. So they are not kind of a certificate way or not kind of the network way. They just using under their own system. So start from the 2022, we have a so-called health called project management office. So the project management office, we need to design the standard and we comply with the international HL7 practice and register with HL7. And under the standard setting, we have the TW Core IG. Right now, we have more than 40 profiles. So we have the IG quality review and the registration management processing. And also we provide the TW Taiwan terminology server. So under this, we have generated interoperable applications based on the FHIR server and the FHIR format, FHIR client. So for another side is we create the talent training and then briefing session to provide our Taiwan's hospital or some researcher to learning and provide the courses and the certificates. And also we have a test platform for the FHIR data self to doing the verification and certification. And also we have information security regulation to adoption the international practice. So, and also we so-called the EEC, the EMR change center, we assessing the EEC architecture adjustment. So we just try to exchange the whole way from the EEC. In the basic, in the past, they just change the data by themselves and using their self format. So we just change the EEC. All EEC's data will adoption the FHIR format in the future, and also based on the smart to doing the OOS 2.0 to doing the data authority and then the acceleration everything. So in the 2022 to the 2024, the healthy cloud PMO, the FHIR implementation, we focus on the standard development is kind of the foundational for similar to the US CDI and the US core. So we continually to developing them and maintain the TW core IG and also the TW terminology service. We have an API and also the HO. We also enhance the API capability to meet the HO7 terminology service, and also we have practical applications for the IG and the tool for including the IG and the tool for registration management. So we also follow the HO7 FHIR registry way to doing that. So right now we have 6 single EMR records IG right now, and then we also convene the relevant organization to establish a nationwide IG based on the proposal needs. So for example, we have a private insurance company. They need to have their own IG to doing the data exchange, and then they have an alliance. So we just doing the consultant and support them to doing that. And also we have the telnet training. We just try to have our Taiwan's professional people. So we just training by ourselves and doing everything for them. And we have the verify. We also design the verification and certification for the marketplace for the product, which one is already passed the FHIR testing, and then everything follow the TW core IG. So we conduct the ongoing and then automate the IG quality review, and also we implement the certification mechanisms for the continually to assess the standard compliance level for the FHIR server and the client, and also the all different kind of the application to create the online testing platform for them. And also we design a different kind of the standard for this kind of this all of the next generation infrastructure. So we try to design a trusted information exchange framework. So including the API connection, the OOS 2.0, the security, and then the all authorization method to doing that. And also we try to have it and then allow the not only the government and the hospital can exchange the data, but also including our industry sites or the private health insurance side to get the data exchanged by themselves directly. So compared to the US core IG to the Taiwan core IG, I think this slide is this calculation is in the end of last year. I think it's in July, so we still have something missing. But right now we already have everything. We just follow the US way to design by ourselves, and then we put our data value sets into our TW core IG to fit for our use scenario. So the next generation healthcare transformation, we will have a committee for everything to review everything and have a more blueprint and then design everything for them. And we still will have the training course and for the IG review and update continually. And also we design the terminology service, not only the law with including the Snowman CT and then mapping the Taiwan local medication code into the Oxnome. And also we have a special interesting group to establish the specialized task force for a unique scenario. And also the national health insurance code, we need to mapping into the low income or into the Snowman City for the interoperability need. And also we have more tools development and verification. We just similar to the TEFCA and the certification. We try to adopt the open source tool to integrate the community driven solution. and also have some product verification and certificates. We try to encourage more private company to design their application and then sell to the hospital to improving this kind of the ecosystem to more fastly and then get more support from the private sides. So right now we adoption of several different international standard right now, and part of them just on the mapping, but not but I think we'll implement it in the end of this year. And we also designed the rule library for the national health insurance and then clinical decision supporting. And the system will based on the smart to get a smart on FHIR app markets, and also we have developed everything based on the smart and also the all acceleration mechanism. In the hospital side, we just we start to create a responsible AI implementation center and then AI verification center and then AI impact research center. To based on the AI model, we need to calculate everything. Is this model can go into the hospital and then is fit for the right now our population health status or is fit for the Taiwan status. And then we need to take a responsibility to supervise it is still stable or not. We need to update the data, update the model, or we just kick it off to the market or not. And also we need to calculate about the AI impact because we are single payer from the national health insurance. So if this AI model is very helpful for the clinical supporting or health nursing care, so we will pay by the national health insurance. But if not, we will just asking the patient to pay for their self, or we just we need government need to discuss with the private company is that also fit for our Taiwan situation or not. And from the hospital side, we have the 3 different level hospital. First one is top one is a medical center, and then is regional or directive hospital, and then is a public health center. So it's because they are a different level, they have a different power to decide everything by themselves. So for the medical center, we plan to asking them to establish the Taiwan data standard just based on everything is FHIR, the exchange from the FHIR. So the medical center use the FHIR data exchange framework to connect to the data center. And the regional site, regional hospital level, we need to plan we plan have established a public version or regional direct hospital with a limited fund can use the public version of the developed customized application software, which means a government try to support them, but not fully support, just part of them. Have some open source service, have some tool, have some supporting to them. And for the public health center side, we try to our government try to provide a public version which can be used directly by the health center and then maintain at the low cost. Is a kind of the open EMR system, and then we will try to have the community to allow the user connect each other and then discuss each other and also design a plugin by themselves. So they are the different levels. So the medical center, they already have their ecosystem, their full functional system. So we cannot try to exchange them or try to change all part of the system. So we just asking them to adoption the FHIR by themselves. And the public health center, they will government will design a free open source code for them and then allow them to upgrade by themselves and then maintain it at a low cost. Yes, so this is our Taiwan's current status. And then is there any question? Oh, before the question announcement, the Taiwan will hosting the MedInfo 2025 in the August 9 to the 13th. So welcome everybody to join. And the early bird registration deadline is in the April 20. So welcome everybody to join us in Taiwan. Okay, thank you very much.
Yes, thank you for the presentation, Sir Billy. Let me just go through the questions in the chat box. We have a question from Dr. Alvin earlier. He wanted to clarify if the health insurance pays for the device.
Part of, not everything, not everything. I think that right now they part of the regulation is pay for the device and with the also including the healthcare service, but not everything.
Yes, thank you, Sir Billy. The next question is also from Dr. Alvin when you were presenting on precision medicine. Um, could you elaborate more on FAIR?
Actually, FHIR is a principle. So-called is a data findable, accessible in, and I is for interoperable. FHIR, and then I think yes, is so-called. Just follow. Just let me find the information. The fair. Oh, it's a reusable. Yeah, here. Let me show you the information. Okay, here. Actually, it's the National Office for the Fair Principle. The so-called the F is for the findable. The data can be findable and then accessible and then interoperable and then it's a reusable. So they have a different there. I can share this organization link in the checkbox.
Yes, thank you, Sir Billy. We also have a question from Dr. Aminul regarding the 16 important data quality dimensions that you presented earlier. So, as per WHO, there are 6 or 7 data quality parameters, but in your presentation, it's 16.
Oh, yes, because we doing the actually we design by ourselves. So the 16 parameter not only for the data, also for the metadata. So for in our perspective is if you want the people can using your data friendly or easy, they need to understand how you design your data structure and then which kind of the data you collect and then the definition of the all different column and then the update the everything. So we just put the metadata and then the data self together. So we just separate to the 16 different parameter. We so-called a dimension. So we just a little bit different. I think the WHO there are 6 or 7 quantity parameter just focus on the data themselves. So how many missing value is a convenience or the related data is correct or not or everything. So we just put it together.
Thank you, Dr. Billy. We also have a question here from Dr. Thomas Nicola Reyes. I think it's related to data quality management and inspection. So, what choice of LLM were used and were agentic flows used to improve unstructured data quality and reliability, or perhaps trigger functions or alerts?
I think because I think in the Taiwan our health record or everything still very sensitive issue. So we cannot just put into the open chat GPT or everything directly. So we just using the llama by ourselves and then we try to get the data from the get the necessary data from the repo. So to improve the quality and then also the reliability. But right now we just we just to the trigger functions and the alerts. We just try to get some for example we try to get some diagnosis information from the image repo, but not really very not really workable right now because in the Taiwan side our doctor, our physician, they write the report by their self-aware and very different and very unstructured. So sometimes it's hard to get that. But in the Taiwan, we in that report, that kind of report, they also use the English, so that is more easy right now. But right now we just try to get a let have a different way. But in the in our research, we just try to get some cancer research data from the report directly to support the hospital side to have a cancer research information more efficiency.
Thank you, Sir Billy. You also mentioned the M-code format earlier. So Dr. Mayank Agarwal is asking if you're familiar if M-code was adopted by India, or
I
maybe
don't
the other
know.
maybe the other participants can also put in the chat if
Yes.
you have an idea. And then about the Taiwan Common Data Model, Dr. Richard Holman Matanta is asking, what is the strategy of Taiwan to ensure that the Taiwan Common Data Model is adopted by the healthcare facilities?
Oh, so actually the strategy is because our project is under our government, is under the Ministry of Health and Welfare. So they have the consortium, and then they asking all consortium need to provide the data directly. So based on that, we did because in our hospital side, they design their system by themselves and very well, and it's long term, it's around 2 decades. So they have a totally different data structure. So in the last moment, we realize that we only can design our structure and then asking them to provide the data directly. So we designed a so-called Taiwan Common Data Model. So basically, you need to create this kind of the data in the list structure for us. But the Common Data Model is connect to the National Health Reimbursement Data Structure directly. So we just based on the reimbursement data structure to design our common data model. And also we design all kind of different tool or system for supporting hospital side to upload their reimbursement data again into our platform. And then we can capture the data directly by our system. So this is our strategy because we are the single payer system. So every hospital, every clinic, they must have the national health insurance reimbursement data, but because they need to do in the client. So basically we start from which kind of data everybody will have, and then we just map into the common data model and we design the data, and then we design the system to collect the data directly.
Yes, thank you, Sir Billy. Actually, we still have a lot of questions coming in. But I think I can call on Dr. Bunchai. Dr. Bunchai, would you like to ask your questions?
Hello,
Hello.
Dr. Billy. Congratulations and thank you. I come late because of I struggling with the SNOMED General Assembly meetings online. I have several questions. Let's go to the top, to the bottom, to the top. I heard that Taiwan really successful on the creating HL7 CDA. But now you are going to the FHIR. How will and what the process that you migrate from HL7 CDA to HL7 FHIR?
Actually, I think in the past, they are not really HL7 CDA. They just part of the CDA. So actually, in the past, in the Taiwan side, we only follow the one format, is the National Health Insurance format. So in that moment, under the EMR Exchange Center, everything is supported by the government. So the hospital side will doing something for them. But the ones that they cannot get any supporting, they will cut down everything. Or just put that there, not keep it maintained. But right now, our Ministry of Health, they collaborate with the National Health Insurance. So everybody mentioned about we will adoption of FHIR, and in the future, even the climate data will based on the FHIR. So you need to prepare it earlier. Otherwise, in that moment, you cannot do in the reimbursement processing. So that is a different situation compared to the past and the right now. So I think they find a correct strategy to pushing the hospital and this market to have a more ecosystem. But I think still very that because in the hospital side, their information system, their information department still they don't have enough human power to design by themselves. And in our market side, because in the past our in the Taiwan the medical information market is too small, because everything is based on national health insurance. It's a very specific situation, so they cannot import, like they cannot export their product to the international market. So not too many people want to do in that and follow this with. But right now, I think based on the FHIR, they can do in the service, and then they can do in the join the international market. So I think that will become kind of a more bigger ecosystem to encourage more people join.
So you mean that right now the National Health Insurance Agency require the
Yes.
FHIR format for exchange data or sending data to the National Health Insurance?
Part of not the basically everything. Let's start from a very mini size. Start from right now. I think because some specific cancer medication application they need to do in the pre-application, and then they can get in the approval, and then they can get the supporting. So they based on the list very small size to doing that. And also we discussed about the next generation sequencing repo to client based on the FHIR, but that's just on the processing right now.
Okay. My last question, I don't want to monopolize the question. Will Taiwan are going to implement SNOMED City?
Yes. And actually, we already joined the country levels member, but you know, country is a very
Sensitive.
sensitive from the Taiwan side. So they are not announced. I think they only have some people join the meeting, but they are not official announced Taiwan as a country member. But I think start from the last year, we already paid the member fee and then join this community, and we also get the all coding and then go get the all license from that moment.
Actually, the last question. Taiwan is very famous on the data bank and Medicloud, and you also have a lot of system. My question is about AI. Does the National Health Insurance use the AI to kind of the audit and detected fraud with the insurance?
That's why the National Health Insurance they try to adoption of FHIR, because they want to doing because okay for for this site, actually in the past they don't have doing that. They just have a lot of different rule-based library to detect, and then to asking the hospital to provide more evidence or more report back. Otherwise they cannot get the money. So for example, in the as I mentioned before, is some specific cancer medication they need to do in the pre-application, and then they can get a fund to treat the patient. So in that moment, in the past, the physician write a lot of different report based on the paperwork. So they will send the application to the National Health Insurance, but the National Health Insurance administration, they don't have many people in the central. So they separate to the north and the middle Taiwan and the south Taiwan sides. They have three or four different center. So the south hospitals application will send to the south center. But that's reviewed by the people, by the different physician. So they don't have the same regulation. So in the Taiwan, they mentioned about, okay, in the Taipei is more easy to get the supporting, because we try we using the same case, or we using the similar case from submit the application from the Tainan and also from the Taipei in the same moment. But the Taipei get approved, but the Tainan get rejected. Why? So they just realize that it's a totally different way in the past. So they try to using this kind of the rule-based engine in the past, but still not AI right now because they don't have enough data to do in the AI for detect by themselves. Even we have the national health insurance for the 3 decades. We got a very huge giant database, but that database only controlled by the National Health Insurance Administration, not provide to everybody to doing the analysis right now. And actually, in another side is because it's Taiwan are the single payer, so the national health insurance get the data or get the client data is based on how many money I can get. So they have the different way to put the condition, to put the procedure, and then they can get a different more high points, and then they can get a more high money, more money in that moment. So that is maybe a part of the data is cannot be trusted in the right now in this moment. So I think they still need to figure out how to fix this properly in the future.
Thank you.
Yes, thank you, Dr. Bunchai and Sir Billy. Sir Billy, thank you again for gracing tonight's AHIN Hour. We appreciate you sharing your work with the AHIN community. And to all our participants, thank you for your questions and for joining us until the end of the session. Sorry, we have reached the top of the hour, so we're not able to answer the rest of the questions live. But we will compile and share them with Dr. Billy and see if we can answer them offline. If Dr. Billy has time to answer them, we'll share the responses together with the recording. All right. Thank you, everyone.
Thank you, everybody.